You're listening to The Voice of Russia in London. I'm Vivienne Nunes, and today my guests and I are discussing the changes being made to the NHS. Just months after coming to power in 2010, the coalition government announced sweeping changes to the National Health Service. Though there had been no word of the plan in the election campaign, the government said structural reforms were necessary if the health service was going to cope with a population that was growing and ageing fast. The reforms aimed to cut NHS administrative costs by a third, while increasing competition from private providers. Some say the changes sounded the death knell for the NHS, famous for its core principle, free at point of use. Others say reforms are necessary to make UK healthcare more efficient, because the system simply can't keep going the way it has been. Nearly 2 years since the Health and Social Care Act was passed into law, we ask, are the reforms working? Or is the NHS itself now in A&E? Joining me to discuss this are Dr. Jackie Davis, a consultant radiologist and co-editor of NHS SOS, How the NHS Was Betrayed and How We Can Save It. On the opposite side of the debate is Dr. Christoph Lees. He's an obstetrics consultant and one of the founding members of the Civitas Doctors Policy Research Group. Finally, joining us on the phone is Gwyn Bevan. He's a professor of policy analysis at the LSE. Thanks everyone for joining me here at the Voice of Russia in London. Now, to begin with, the outgoing head of the NHS, Sir David Nicholson, recently told a Health Select Committee that privatisation and competition were not proving to be a success. Was he right, or is it too soon to judge? I'll start with Dr. Christoph Lees.
Well, it's very difficult because whenever anyone talks about privatising the NHS, you're left wondering exactly what is being privatised. So does it mean that hospitals are being wholesale sold off to the private sector? Does it mean that GPs become effectively private companies? We don't really know. And the way that privatisation has tended to work over the last 10 years is probably not the right way of using the private sector. So NHS funds have been used up to have patients treated in the private sector. Now, that's not a bad thing if you desperately in need of capacity for certain types of extra operation or treatment, but it is a bad thing with long-term planning because it means that you do deplete capacity in the NHS and you are tending to send the patients with the more simple categories and easy to deal with problems to the private sector. So that is what privatisation, that's really what it's tended to mean in the NHS over the last 10 years. I'm an NHS consultant, and by far the majority of my work is in the NHS, so I have an absolute vested interest in the NHS working well. But I think that because we have this mindset about the word privatisation being bad, what we forget is that very many countries in Europe have extremely high quality, largely public health systems where significant amounts of healthcare is performed in the private sector.
I will come back to that a little bit later on, but first I just want to get an initial response to the first question, and that is, are these reforms that we're seeing just starting to take place now working? So I'll go to Dr. Jackie Davis for now.
No, they're really, the wheels are coming off very quickly with these so-called reforms. It is privatisation, of course, by every definition, including the World Health Organization, when public services are delivered increasingly by private companies. We're seeing people like Virgin and Serco winning these great big contracts, and in fact 22 out of the last 24 big contracts that were awarded went to the private sector. All this talk about it going to third sector social enterprises is of course nonsense, because they can't afford to bid for these things. So it is privatisation. And David Nicholson himself had to stand up and say it's really destroying the heart of the NHS, because the whole principle of healthcare is for people to combine and work together for the good of the patients. And what you've got now is a field day for competition lawyers as hospitals start to quarrel with each other about who's going to deliver services. You can't plan what's going on. And we heard recently, after David Nicholson stood up and said this, that cancer services are now being impeded because hospitals are squabbling over who's going to give them, because patients mean money. And that is absolutely the wrong direction for the NHS. My colleague mentioned European countries who, of course, spend much more than we do on healthcare, and that always has to be considered when people talk about how good European systems are. Is it too late? That's a very, very good question, and one that we really need to spend a bit of time on, because a lot of people think it is and it isn't. There are some very basic things that can happen now that will rescue. There's a big chunk of the NHS still to defend, and we must do that, but some things have to happen quickly.
Professor Gwyn Bevan, what's your view of the past sort of year and a half and the changes that have been put in place so far? Are they working?
Well, I think I'm not in touch with the way things are happening now, the way that your two speakers are in the studio. But what I do know is, looking back over the evidence of provider competition, and we've been trying that for a very long time at different models in the English NHS, and the evidence is there's very little evidence that it works. And one of the big problems that we've had is the so-called purchasers or commissioners have never worked well, effectively. I mean, studies consistently find that. And one of the things that causes us all so much grief, which is what you alluded to in your introduction, is one of the reasons they don't work very well is they keep on being reorganised. And the coalition government promised in its programme for government there would be no more top-down reorganisations of the NHS. And David Nicholson actually described the one that's happened as so big you'd see it from space. So I think that there are real worries here over the capacity of the purchasers to actually manage competition choose between providers. And the sort of issues that we face in terms of an ageing population with resource constraints is that what you want to focus on is not so much competition between providers, but developing integrated care across organisations. And the nature of market competition between providers sort of gets in the way of doing that.
I want to come back to something Dr. Lees mentioned earlier. You've said there's a system that many European countries have adopted that works perhaps better than what's happening here in England. I know you've suggested a social insurance funding model. How does that work?
It's a very popular model if we just take France, Germany and Switzerland. In fact, it is the model that the NHS might have become, and we wouldn't be sitting here in this studio had it become that. When William Beveridge in 1941 was commissioned to write a report on social and health care, he came out with a very innovative scheme allowing everyone access to health care. So every person in the country had a social insurance premium. And he said that it was a peculiarly English solution in that you would have universal coverage, but you could also pay above that what you wanted if you wanted to access different sorts of healthcare in different sectors. He didn't quite say that, but that's paraphrasing. And what it means on a simple level is that individuals, let's just take Switzerland, you can purchase a social insurance policy. In fact, you have to. It's compulsory. It's a little bit more expensive than the NHS. In fact, it's considerably more expensive than the NHS pays per person, per capita, per year. But it gives you choice. And it also means that many publicly provided hospitals and independent sector provided hospitals are thriving and doing extremely well. And it furthermore means that if you want to purchase an aspect of care that wouldn't be funded through that basic premium, you would be free to pay on top of that if you wish to. But it does mean that everyone gets a very good basic standard of care. Now, we heard earlier that England and Wales spend a little less than many European countries. That's true, but it spends about the same in public health spend. So the difference between us and the Swiss Germans and French is the amount of voluntary pay, the amount of money that people pay on top of that for their health care. And there is a lot of evidence to suggest that patients in the UK are perfectly happy to pay a little extra to access sorts of healthcare that they wouldn't normally. But at the moment, private healthcare, as it is in the UK, is cripplingly expensive. So the vast majority of people on middle and lower incomes cannot access private healthcare. That is something that social insurance could change. And it could also mean that NHS hospitals would suddenly find a funding stream that they previously didn't have and bring in revenues into the NHS, which we all know and love.
Can I just come in there? A few years ago, I wrote a paper with a Dutch scholar, Wiener van der Ven, on thinking about the Netherlands pioneered this system of competing social insurers. I thought it was an interesting one to consider for England. But I know that in the Netherlands at the moment they are troubled about that system because of the escalation in costs of healthcare. So it featured in a recent election there. And I was at a conference in New England about a month ago, and people from Switzerland were saying that the Swiss system is now an issue in their elections as to whether they will continue to do that because they're troubled about the way it works. So I think it's a very interesting idea, but there are two things about it. One is it has very serious regulatory problems, and the other is that in the Netherlands, it took them 20 years to introduce this. It's a very complex system to get in place with regulatory bodies, and what troubles me about England is the capacity in which we keep on reorganising what we do. So I'm not sure we'd ever have the stability we'd need to get the system to work, and even where they have implemented it, it's obviously experiencing problems at the moment.
Those points are absolutely well made. I, too, travel around Europe and occasionally outside Europe to look at healthcare systems and have these debates. And the one unifying factor of every healthcare system is that everyone always complains about their own. So the Swiss, the Germans, the French, the Canadians, and of course the Americans, which is a completely different story, always complain about their own health systems and the cost of them. So I'm not sure I would judge the success of a model based on that.
If there was a perfect way of delivering healthcare, we'd all be doing it. So we've all got different ways of doing it, and I don't think there's anyone who does it in quite the same way. The fact is that by a lot of international standards, we do have the most cost-effective healthcare system in the world. And before this government came in, and I'm not making a political point, I'm just saying that's when these reforms came in, it was at its most popular ever, and where the outcomes were really improving. So it wasn't broken when they came in and started these reforms, and it really didn't need fixing. And now we've seen all the problems that have arisen from their decision to have another redisorganisation, as my colleague said here. The problem with this rather two-tier system that's being described is that one of the great things about the NHS is that it's been equal for everybody, and you couldn't come in and pay a bit of extra for a top-up or a co-payment, because once you go that way, you have a two-tier system, and then people start to feel, well, that guy in the next bed's paid for a bit more than I can have, and doctors have to start thinking about this person can afford this and that person can't afford it. We've never had to say as doctors in this country, somebody under the NHS can have it and somebody else can't. You know, there's a lot of talk about the money, the big financial problems for the NHS at the moment, but the fact of the matter is that because of what somebody's referred to already as the purchaser-provider split, in other words, you divide the NHS in two and, one side buys from the other, the administrative costs, and people's eyes, of course, glaze over when you start talking about this, but it's very important in terms of finances. The administrative costs have gone up by about 10%. And with a budget of 100 million, that's £10 billion a year spent on administering a market which really nobody thinks works. So if you want to claw some money back that we can invest into a system that was actually working very well before it was turned on its head, then take that £10 million back. There are other things we can do, of course. But if you have a rump service and then people can pay for better, the danger is you end up with a poor service for poor people.
You're listening to The Voice of Russia in London. I'm Vivienne Nunes, and on today's discussion programme, we're assessing the Coalition's reforms to the NHS. Dr. Davis, you've said there's risks in creating a two-tier system, but is there no room for perhaps some sort of privatisation for elective surgery or things that would otherwise clog up the health service? Is there no room to give people the choice to perhaps pay for operations that might not be necessary?
Well, there's already a private healthcare system in this country, of course, and as my colleague has pointed out, that tends to be rather expensive, and they make a lot of money out of the NHS. But what we would like to see as people who defend the publicly funded and publicly delivered NHS is an NHS which is comprehensive, and it is possible for that to happen now. The problem is once you start giving contracts out to the private sector, the cost goes up. The transparency goes down. They're no longer accountable. The National Audit Office have recently produced a big report, which unfortunately nobody noticed, saying we've got real worries about this outsourcing to the private sector because we don't know what they're doing. They're not subject to freedom of information. We don't know about their profits. We don't know about their outcomes. And guess what? They're not paying taxes. They're taking their money to offshore accounts. So they're not even putting the money back into this country. So there are a lot of problems. I'm not so ideologically committed to the NHS. I wouldn't say if it helps patients, then let's put some of it out to the private sector until the NHS can manage. But those of us who fight for the NHS believe that the NHS can manage if it's properly funded and properly managed as it used to be.
Several interesting points there, and I'll be as brief as I can. We don't just have a two-tier system. We have a three-tier system. We have those that can't get what they can get locally, which often, not always, but often isn't very good. We have a very highly literate and educated middle sort of group of middle-class professionals, people who push for what they want to get, and they generally do, and who can blame them. And then you have the wealthy who go privately. So we have an explicit three-tier system. The key is to get some of those people who are disadvantaged and disenfranchised because we patronisingly think the state must provide everything for them and they're not intelligent enough to work out how to spend their own money, and they end up getting at the bottom of the pile, and they would if we had a purely publicly funded, publicly delivered service.
Professor Bevan?
There are a set of complex, interesting issues here, but I mean, at the heart of what the current reforms are about is a belief for which I see very little evidence that provider competition will work and improve healthcare. And when I was discussing the Dutch model with Bernard van der Ven, who's the scholar who's a big architect of reforms and very enthusiastic about them, a few years ago, he was saying that what's happened in the Netherlands through the reforms, it's shaken up the insurance markets. They've gone from a large number of insurers to a relatively small number. And clearly there have been savings there. So that was beneficial in terms of addressing the issues they had through a social insurance scheme. But there's hardly any change at all in the delivery of care. And we're back into this fundamental difficulty about the extent to which the contracting system works and the purchasers can actually improve healthcare. And the big issue that they had in the Netherlands, which we all have, there's a lack of data to compare quality of hospitals. And what Bernard was saying is that the people who choose between insurers will be deeply troubled if an insurer switched to contract because they would think they're doing it purely on grounds of cost, not on quality. And so until we actually have a really good system in which we can compare quality across hospitals so people can trust the choices that are being made, we shouldn't really be moving towards provider competition. And I also think the evidence is very, in the States when they put information out, the studies of hospital report cards, patients just don't use this information to move. In New York State, they had a very good system of reporting cardiac surgery mortality rates. And to their astonishment, people kept on going to hospitals with very high mortality rates. So I think there's a fundamental, at the moment, the case for provider competition is extremely weak, and that's at the heart of these reforms. And I don't see evidence from either the Netherlands or the States as suggesting this is an effective way of improving healthcare in England.
Well, there's a lot of truth in that, and certainly the model of bringing the private sector into the NHS or into Britain's healthcare has not been a tremendous success, and it's not a mechanism that one would choose. It was very obvious that we were going to end up in this position, but that unfortunately means that we then don't think of more innovative ways of allowing people choice and bringing the private and independent sectors into the whole system.
You're listening to The Voice of Russia in London. I'm Vivienne Nunes, and today my guests and I are discussing the changes being made to the NHS. I'm joined by Dr. Christoph Lees, an obstetrics consultant and founding member of Civitas Doctors Policy Research Group. Also in the studio is Dr. Jackie Davis, a consultant radiologist and co-editor of NHS SOS, How the NHS Was Betrayed and How We Can Save It. Joining us on the phone is Gwyn Bevan, Professor of Policy Analysis at the LSE. Dr. Jackie Davis.
The real problem is that nobody seems to be addressing at the moment is that we've lost 50% of our hospital beds in the last 20 years, and that simply needs to stop. I was speaking to an A&E consultant a couple of days ago about this so-called crisis and asking him, is there a crisis and why? And he said it's about this loss of hospital beds. We've got very acutely ill people in A&E. The government pretends that we don't need hospitals, but in fact, if you work in one, you'll still see they're full of ill people. And we can't get them a bed because they've had all these bed cuts. cuts, particularly under the private finance initiative. A lot of hospitals lost beds. And then once they're in the hospitals, we can't get them out again because the replacement services that were supposed to be put in place to keep patients in the community simply haven't materialised. There's also 50% vacancy rates in A&E consultants at the moment. And so there is a lot of pressure on the system. But unfortunately, nobody ever says that the NHS is perfect, and it clearly needs to evolve and improve the whole time. But it has been disorganised every 2 years for the last 30 years. So when you've got no stability, you can have the best system in the world, but if every politician who comes along reorganises it to suit their own ideology, which is certainly what happened when the coalition came in, the staff have no stability, and you do not have the stability to look at the system and say, OK, there are things going wrong here. Within a stable system, we'll address them and try and get them better. So the staff of the NHS, and by that I mean the frontline staff, are constantly dancing on a moving carpet, trying to accommodate all these changes while looking after patients. And of course, the managers are subject to these huge political pressures, which they then pass down to the staff. So all sorts of predictable problems occur with bullying and fudging waiting lists and that sort of thing. What the system needs, which is basically a good system, is some time to settle down, look at itself, improve itself, but not to be changed by another lot of people.
Is that possible at this stage, though, Dr. Leith?
If we look at many European countries, and I'm sorry to go back to social insurance, which, as you can tell, is a hobby horse of mine, we find that there are many more beds in the hospitals. They don't operate at this ridiculously high level of occupancy that we do in the NHS. There's no doubt that this will always mean every time you're tipped over the edge by a flu epidemic or cold weather or asthma because there are problems in the air, suddenly you fill up and you clog up everything. So in a drive to run very efficiently in the NHS, we don't run efficiently because the occupancy is far too high.
Why aren't those beds occupied in Europe then?
Because they realise that to run a healthcare system, you have to have a certain degree of slack. You simply cannot operate on 98% occupancy. It's the same in neonatal intensive care, it's the same in A&E, same in GP surgeries. If you have every appointment filled and every seat full, you will not be able to respond properly. But if we go to another fundamental point, which I think is the way of dealing with this, is not to reorganise. I absolutely agree with my other two colleagues here that reorganise after reorganise, the supply side of this, which is the hospitals and clinics, is absolutely the wrong thing to do. What we have to do is reorganise the demand side, which is the money. And the money will probably run to largely the same paths that it does at the moment, and the large hospitals and the good clinics will continue to be funded very well, but it'll enable marginal changes and marginal choice effects that will improve it for everyone.
But if we see a change of government in 2015, aren't we looking down the barrel at yet more reorganisation? Dr. Davis?
I think there are a few things that need to happen that could happen very easily when a new government came in. First of all, Labour needs to say now that they will end the market, because that'll send out a signal to the private providers that their time is limited and will, with any luck, would really discourage them from getting involved. They also need to say that they will back Lord Owen's bill, which is a very short bill which asks that the Secretary of State takes back responsibility for delivering a comprehensive health service, because what the coalition very deliberately did was to distance the Secretary of State from looking after the health service. They need to stop cutting beds so that we don't need a huge redisorganisation again. This could be reversed very easily without really much trouble at all, and that message needs to go out to people. We haven't lost the NHS, it's still worth fighting for, and there are some very simple things that can be done to reverse the process.
Professor Bevan, did you want to come in now?
It's a really good question, and I think that it's very difficult because on the one hand, we're all in agreement. There's this constant organisational turmoil. There's such a distraction, and in part, I think the reason we're in the mess that we're in is because people have taken their eye off the ball. Instead of thinking about, I mean, Stephen Dorrell's, select committee, in effect, made this point. He was a former Secretary of State for Health in the last Conservative administration, that at the time of austerity stretching so far as the eyes can see, the last thing you want is people to be worried about how you get a completely new complex system like this to work. So on the one hand, you feel you wouldn't want a reorganisation, but given the system we've got, it just looks to me completely unworkable at the moment. So it's so difficult, but I just don't think the system we've got is is going to work. And I mean, the other issue we haven't really touched on is the massive regulatory problems we have once you move to pluralism and competition between providers. It's much harder to regulate quality of care. The Care Quality Commission has had all sorts of problems in doing that. And you've then got a separate economic regulator. So, and I, like many others, don't think that division of regulatory responsibility works. And the final point I'd make is what's interesting is that in the United Kingdom, Scotland has actually abolished the purchase provider split, gone back to an integrated healthcare system. I'm working on a report at the moment comparing the 4 countries. And Scotland seems to be matching English performance now. And my prediction is that in a few years' time it will be outstripping the performance of the English NHS.
To draw this debate to a close, I'd like to ask each of you what you would do if you were put in charge of the NHS or given the health portfolio in Cabinet for a day. What would you do, Dr. Lees?
Just one point. Scotland's funding is, of course, very significantly greater than England and Wales's funding, which may help us explain why they are doing much better. No, I would not reorganise the supply side. I would look towards having a model of funding that would accommodate pluralism. So it would mean that everyone had a very good basic standard of care and others were able to top that up, whether by cash or by insurance or however they wish to, or with employer contributions. And then suddenly we would bring more money into the whole system, and that would benefit the NHS and the patients that didn't pay extra too.
Dr. Davis, if you were Secretary of State for Health?
I think the first thing we should remember is that what patients really want, the real patient choice, is good local services. Choice comes very far down the list of what patients want, and it's been used as a Trojan horse to get the private sector in. I wouldn't go for top-ups and co-payments. I think they lead to two-tierism. I would stop the privatisation process. I would take back to centrally the PFI debts, which are crippling hospitals at the moment. And I would be very proud of our NHS because I think it's a terrific social institution that people rightly value, and we've got to get it back from the vandals.
And finally, Professor Gwyn Bevan, if you could wave a magic wand and improve the NHS, what would you do?
Can I just make one point about the England-Scotland comparison, which is that although Scotland has higher per capita spend than England as an average, if you look at the North East, the level of spend in the North East region is similar to that in Scotland. That's the one we were using for these comparisons. As regards the future, I mean, I just think the whole market-based provider competition is a mistake, and you ought to move towards, I think, a process of evolutionary change so you can better have integrated care, particularly between primary, community and hospital services. And I think the provider competition just gets in the way of doing that. So you'd want to have a gradual evolutionary change to a high-performing integrated healthcare system.
Well, it's clear this debate will continue right up to the next election and beyond, but I'm afraid that's all we have time for today. I'd like to thank each of my guests for joining us. Dr. Jackie Davis, consultant radiologist and co-editor of NHS SOS, How the NHS Was Betrayed and How We Can Save It, Dr. Christoph Lees from Civitas Doctors Policy Research Group, and Dr. Gwyn Bevan, Professor of Policy Analysis at the LSE. Thanks everyone for your time. Now in A&E. Joining me to discuss this are Dr. Jackie Davis, a consultant radiologist and co-editor of NHS SOS, How the NHS Was Betrayed and How We Can Save It. On the opposite side of the debate is Dr. Christoph Lees. He's an obstetrics consultant and one of the founding members of the Civitas Doctors Policy Research Group. Finally, joining us on the phone is Gwyn Bevan. He's a Professor of Policy Analysis at the LSE. Thanks everyone for joining me here at the Voice of Russia in London. Now, to begin with, the outgoing head of the NHS, Sir David Nicholson, recently told a Health Select Committee that privatisation and competition were not proving to be a success. Was he right, or is it too soon to judge? I'll start with Dr. Christoph Lees.
Well, it's very difficult because whenever anyone talks about privatising the NHS, you're left wondering exactly what is being privatised. So does it mean that hospitals are being wholesale sold off to the private sector? Does it mean that GPs become effectively private companies? We don't really know. And the way that privatisation has tended to work over the last 10 years is probably not the right way of using the private sector. So NHS funds have been used up to have patients treated in the private sector. Now, that's not a bad thing if you desperately in need of capacity for certain types of extra operation or treatment, but it is a bad thing with long-term planning because it means that you do deplete capacity in the NHS, and you are tending to send the patients with the more simple category
that was growing and ageing fast. The reforms aim to cut NHS administrative costs by a third, while increasing competition from private providers. Some say the changes sounded the death knell for the NHS, famous for its core principle, free at point of use. Others say reforms are necessary to make UK healthcare more efficient, because the system simply can't keep going the way it has been. Nearly 2 years since the Health and Social Care Act was passed into law, we ask, are the reforms working? Or is the NHS itself now? You're listening to The Voice of Russia in London. I'm Vivienne Nunes, and today my guests and I are discussing the changes being made to the NHS. Just months after coming to power in 2010, the coalition government announced sweeping changes to the National Health Service. Though there had been no word of the plan in the election campaign, the government said structural reforms were necessary if the health service was going to cope with a population